There we go. So our next speaker is Dr. Moise Lieberman. He is a thoracic surgeon, director of the CHUM Endoscopic Tracheobronchial and Esophageal Center. Tracheobronchial, what did I say? And the inaugural medical director of the multidisciplinary CHUM robotic, endoscopic, and minimally invasive surgery program at the Centre Hospitalier de l'Université de Montréal. Welcome, Dr. Lieberman.
Thank you very much, and thanks Normand and John for inviting me. Really great to be here and great to see all of you. I'd like to say I agree with Magali on everything she said. I think, is that better for you? Yeah. I agree with everything she said. I think actually we use SPRT a ton, and I think radiation oncologists use surgeons a ton, medical oncologists use surgeons. We all use each other, and if we can work together for the best of the patient, there's many, many times I sit in my clinic and I say, thank God we have good radiation oncologists, because there's a lot of patients we don't want to touch, so it's always good to work together. I'm going to talk to you a little bit something maybe futuristic, not ready for prime time, but something we are investigating here in Montreal, and what I think the future may be for early stage lung cancer. Endobronchial surgery, from diagnostics to therapy, and I'll talk mostly about the therapeutic options. These are my disclosures. The ones in yellow are conflicts for this talk, so just to keep those in mind. So when I see this patient, do I really need to operate on this patient? The patients all want surgery, I'm not sure. What about these patients? And I think these we're seeing more and more with lung cancer screening, with follow-up after surgery, with follow-up after SPRT, all of these patients with multiple GGOs. We scan them every 6 months. It makes them crazy, makes us crazy, costs a lot of money, a lot of radiation. Do we need to follow these? Should we operate on them, or maybe there's another option? We know the options for ablation. One is surgery. That's what I do a lot of my life. We have Magali for radiation therapy. We have transthoracic percutaneous with the radiology colleagues. And today I'm going to talk mostly about endoscopic and robotic lung cancer ablation. So the advantages of an endoscopic ablation modality compared to percutaneous route is that we don't need to pierce the pleura. And again, as thoracic surgeons, pneumothorax is really not an issue for us. We cause pneumothorax pretty much every day when we operate on the lung. But what's the problem is chronic fistulization when you put a heat or cold catheter through the pleura and then treat a patient over 10 or 20 minutes. And that's why, in general, even though percutaneous ablation has been shown to work, and I'll show you that, a lot of patients are not getting ablation in the percutaneous route because of the complications and the risks of bleeding. We, for many, many years, couldn't get to the tumors. And you all understand the anatomy well of the tracheobronchial tree, but as I explained to my patients, most of the tumor occurs in the leaves of the tree, not in the trunk or the branches. And until recently, we had a very hard time getting into the periphery where the majority of lung nodules, lung cancers, and GGOs occur. Even with navigational bronchoscopy, we are really not able to go out into the periphery with accuracy. And when you talk about diagnosis, that's okay. If you miss the diagnosis, you follow the patient, you send the patient to radiology. There's some way to regain that tumor if you missed it. But when you talk about ablation, there is no margin of error, and you need to be sure that you're in the right place. When you're doing bronchoscopy, for those of you that don't do endoscopy, you really don't know where you are once you're out in that tree. So when you do SPRT, you have a scan in real time and you know, but we're in this sort of airway tree and we don't know where to go. So GPS technology, navigational bronchoscopy are pretty terrible as ways to get to tumors, even though they're good enough for some large tumors and for tumor biopsy. But recently we have robotics. There are 3 companies that are FDA approved, one which is approved in Canada, the Auris Monarch from Johnson & Johnson, Intuitive Surgery has the Ion, and Noah Medical has Galaxy. These robotic bronchoscopes are allowing us to do GPS navigation into the parenchyma, and I think of it as swimming in the ocean. So when I do regular bronchoscopy or navigational bronchoscopy, I'm limited by the trunk and the trees. But when I do robotic bronchoscopy, I can exit the branches, and I can go anywhere in the leaves that I want, like I'm swimming in the ocean, because I'm able to control my scope with real-time radial endobronchial ultrasound and intraoperative CT scanning. We can know exactly where we are at all times, and even if we're not in the tumor, we can adjust. You see we're using like a little Xbox controller, depends on which system you use, but you can go anywhere you want. And as I tell my kids, the one advantage they have when they play Xbox that I don't have is that we only get one life, but usually they get 3, so it's easier to trick. So anyways, that's what we're doing, and we're able to get to the lesion. Now that we're able to get to the lesion, it opens up a lot of possibilities for ablation or treatment of tumors, which we didn't have before robotics. We are participating in the POWER trial. This is a trial for metastatic lesions to the lung, not lung cancer. And really the goal of this trial with microwave ablation is to allow us to go and treat these tumors as opposed to doing segmental resection or SBRT for patients with limited stage disease. It's really a safety and a feasibility trial. We're not looking at overall survival for outcomes. And you can see here a navigational bronchoscopy with real-time fluoroscopy and cone beam CT in 3D, where we assess the tumor, we choose the ablation zone based on tumor characteristics and size, and then we can place our ablation catheters either next to the lesion or we can bracket the lesion on either side, and we can ablate. And these are just some of the patients that were done at the CHUM. We're fortunate that we've done more cases than anyone in the world in Montreal. And you can see a left upper lobe small lesion. This is a left lower lobe lesion. Here's a lesion in the left upper lobe, very close to the pleura. This patient is right upper lobe, and this was our hardest one, right next to the heart in the lingula. And all of these patients were ablated successfully and have been followed over a year without complication. So what are the modalities for ablation? There's heat modalities and there's cold modalities. They both have their advantages and disadvantages. Even though we're doing microwave ablation presently at the CHUM, our real interest is in cold ablation or cryoablation. Some of the benefits, sorry. Maybe I'm too excited about the robotics and I'm bouncing a lot, sorry. Some of the real advantages to cryo as opposed to the heat modalities, cryo is just cold, it's like making a little popsicle in the lung, is that the risk of bleeding and bronchopleural fistula is much less because all you're doing is making an ice ball and then you're letting it go or letting it thaw. The other main advantage to cryo over heat modalities and even radiation, I know, and I don't want to offend any radiation oncologists, but everyone talks about the abscopal effect. When you burn things, there is not much abscopal effect, in all honesty. Charring doesn't help let off cell signalers, but when you do cell death by apoptosis and cell swelling, you actually let off all of the intracellular organelles, so you can have abscopal effect. I'm not saying there's none with radiation, but it's very, very low. And with cryo, you get all of that advantage. And I'll show you results of a trial that we're doing at the CHUM. So the nice thing about cryo is that it's safer. We know that it is effective because there is studies, and I'll show you that. The real disadvantage is it takes longer than the heat modalities, where you can ablate patients with heat in 1 to 2 sessions of 5 to 7 minutes. In cryo, you're talking about more 10 to 15 minutes per session. It really doesn't affect the patient, but more for the physician. And for those of you that know me, I don't have a lot of patients. But once you put the machine on, you can go and do your emails. So we are looking at cryoablation. We're trying to assess different catheters and different gases to ablate tumors in situ, both in ex vivo tissue and in animal tissue, with the goal to be in human clinical trials within the next 2 years, hopefully, it might be 3. We use the Joule-Thomson effect, which is really the change in temperature that accompanies the expansion of the gas without the production of any work or any heat, and that allows for freezing. And really, when you see ablation, you can see it in real time under CT scan. It's very obvious, so you can know your ablation zone, and you're really just making an ice ball or a popsicle in the lung. what you need to understand about cryo, if there's any interest, is it's not like cryobiopsy. So currently, when we do cryobiopsy in the lung, we're using either CO2 or N2O. Those cryogens are very good and they get cold, but the ice ball they make is about 1 centimeter because they're not cold enough. The helium and hydrogen can either cause explosion or heat at a certain temperature, so they're not safe, and we're really looking at the nitrogen, argon, oxygen, and liquid nitrogen for the best cryogens to get you down to the minus 250, minus 300 degrees Celsius, as opposed to the cryobiopsy, which is about 50, 60, 70 negative Celsius. And with that, you can get those large ice balls. We know that cryo works because cryo is actually FDA and Health Canada approved for cancer ablation, not just in the lung, also in the kidney and in the liver. This is a device called IceFX. It was an Israeli company called Galil Medical, which was bought by Boston Scientific a few years ago and is being marketed and sold. We have it at the CHUM. I'm pretty sure that the MUHC has it as well for kidney, and I think the Jewish might have it as well in the other hospitals. So we know it works. There is studies showing that for metastatic lesions, it is effective and it is safer than heat. The problem is there is a much higher risk of bronchopleural fistula with these technologies compared to SBRT or surgery. And I won't go through in the interest of time, but there's multiple studies in the radiology literature showing that ablation works. The problem is the radiologists are not sent these patients in general unless they're either non-surgical candidates or non-radiation candidates because of ILD or other risks, and then they get the last pick of these patients because of the risk associated with that percutaneous route and ablation. Whereas TTNA is very, very safe because the pneumothorax are usually small unless the patients have severe emphysema. In ablation, it's a different story. I won't show you that. So as I said, we have a large program not only in clinical ablation of tumors at the CHUM, we also have a large research program looking at new technologies for ablation of the lung, and we're trying to develop catheters and ablation systems for the next generation of cancer treatment, and that's done in conjunction with multiple companies. This is some example. We're very fortunate at the CHUM to have a very large lung transplant program. So when patients are undergoing lung transplant, pretty much 100% of them will consent to give away their bad lungs because they're getting new lungs, and we take those lungs right away fresh, even at 4 in the morning. Sorry for the research fellows who are here. And we put them on a ex vivo lung ventilation perfusion machine, and we're able to test novel technologies on perfused ventilated sick lungs with ILD, COPD, sometimes cystic fibrosis, although thank God that's gone away. And we're able to develop not only the probes, but also the algorithms for the time and for the temperature that we need to kill these tumors. And our next step is to be in the animal lab looking at an onco-pig model for lung cancer ablation. As I said, we are looking at the abscopal effect as well. This is a study done by one of the fellows in oncology, Antoine Desilets, at the CHUM, looking at stage 4 lung cancer and abscopal effect related to cryoactivation as opposed to ablation. And I can't give you all the results because the study has not been published, but just to say there is immune modulation with cryo for metastatic lung cancer. I believe and I hope that in the next few years we'll be able to treat lung cancer and early stage lung cancer, specifically lipidic adenocarcinoma, like the colorectal people and the gastroenterologists do with polyps. When they do screening and they see a polyp on colonoscopy, they take it out. Sometimes it's benign, sometimes it's malignant, sometimes it's precancerous, but the patient goes home and doesn't need to worry. Right now we do lung cancer screening. I see Nicole, she's a big proponent, and thanks to her we have this program in Quebec. We screen and then we have no idea what to do with these people. It's stressful for them, it's very stressful for us. It costs a lot of money, it's a lot of radiation, a lot of time, and I think within the next few years, if we have a safe alternative where we can go in with a bronchoscope, biopsy the lesion, stage the lesion, and treat the lesion, patients could have the one-stop shop for lung cancer screening where they would come in and go home cancer-free without needing recurrent follow-up, and hope we're gonna get there soon. I wanna just thank my team, really lucky to work with amazing people. It amazes me every day that these people actually put up with me, but I'm very lucky to work with them, and all of this is possible only because of these people. And I really thank you for attention and happy to take questions.
Questions? So I would like to know, as you see these things evolve and get implemented over the next 10, 20, 30 years, where do you see things happening in terms of, is it in the hands of the surgeon or the interventional respirologist? And is it something that's going to stay academic, or as a community respirologist, is this something you think gets implemented in multiple centers?
It's a great question, and I think the answer is yes to all of that. I think that if you do something well, you do it well. And if you're a pulmonologist and you do interventional endoscopy well, then good for the patient. And if you're a surgeon and you do that well, good for the patient too. Do I think that a surgeon that does lobectomies and esophagectomies every day and toilet bronchoscopy but no interventional bronchoscopy is going to be able to do robotic lung cancer ablation? No, neither will they want to do it. Do I think a pulmonologist who does sleep and COPD and some lung cancer who does very little bronchoscopy is going to do robotic bronchoscopy and lung cancer ablation? No, but neither does that person want to do it because it's time consuming, it's stressful. You also have to become a lung cancer treatment doctor, and not everyone wants to do that. So I think that good people should do the procedures in a good way, and whatever your training is, as long as you're doing a good job for the patient, I have no problem with that. I think that this will all eventually go to the non-academic centers, just like the academic, if it works. And robotic bronchoscopy will get easier. It will get cheaper. Right now, it's very, very expensive. Right now, it looks easy, but it's not that easy, okay? You have to learn cone beam CT and how to navigate under real-time fluoroscopy, which is a skill that nobody has. You have to develop that skill. The cost per procedure without the ablation in Canada is over $5,000 after the $1 million you paid for the robot. So that will all come down as there's more competitors on the market. But my hope is that this will be done in every hospital. When we started doing EBUS, I remember when I came back to Montreal in 2009, started doing EBUS, we were really doing EBUS in a few academic centers in Quebec. Now every hospital, not every, but almost every hospital is doing it. I think people are doing a great job, and I think this could be the same thing. Again, it's a hypothesis. I can't guarantee that any of that is true.
Yeah, question?
No, I just would like to make a comment about that because, once you have a hammer, everything is a nail, and I disagree with you a little bit about community interventional pulmonologists doing this. It's not a procedure. This is, look at us all of here sort of being deeply involved in understanding lung cancer biology, how cancer behaves and everything else. I mean, I could argue with you that every lesion that's in a visceral pleura less than 2 centimeters could be resected through 2 5-millimeter incisions and maybe 1/12. The Insignia stapler is so good you don't have an air leak. You give an exparel block and take the chest tube out, and it's a one-stop shopping with a complete resection of the lesion and total pathology. I think technology and advancements are amazing, but I also think that the people who are using this should be cancer experts rather than just technicians to say, I can ablate this. It's akin to, let's say, IR doing all the peripheral leg work in vascular and then having vascular surgeon on standby for complications, or cardiac guys doing TAVR and cardiac surgeons sort of sitting there. Are we going to be as surgeons kind of sitting there for potential complications for some of these? I think it comes down to teams and understanding the disease process and treatment of it all.
I couldn't disagree more. Sorry, I couldn't agree more. But I would say that in a non-competitive model where you're actually trying to do not only the best for your patient, but the best for your patients at large, it's really not scalable. Meaning, if you think about neoadjuvant therapy as an example, and surgery after neoadjuvant therapy, if just John and I were doing all of the neoadjuvant surgery for Quebec, patients would be waiting at home for 7 months, dying of brain mets before we would get to operate on them. And community surgeons are doing a very good job operating on these patients. Don't forget, if you're a community surgeon or a community bronchoscopist, you were trained somewhere. And usually you're trained by a guy like you or like John, and hopefully you learned it well. I don't think when things get busy or big enough, it can only be done in the academic centers. I would like, I used to think that, but I realized with time and being on all of these committees that a lot of us are on, it's just not scalable. And of course, there's one person in the US or in Canada or in Europe that's better than other people, but I don't think that person can treat everyone. So that's my personal take. Again, these things will always start in the academic centers. I think we saw it with EBIS. I think that at the beginning it was all done in academic centers. Now we see it all over. SBRT was the same. 10 years ago in Quebec, as an example, there was 3 hospitals doing it. Actually 1, then 2, then a third. Now, I don't know how many, but pretty much most centers have it. But all of those radiation oncologists that are doing it are trained by people like Magali or other of these experts. So anyways, agree to disagree.
Thank you.
You tonight at dinner. We can go on to the next talk. Yeah, thank you very much.
Thank you.